I can text him.
Oh, are we live yet?
No, quite.
We are live streaming.
Yeah, but we haven't started.
Sorry if I seem quiet. I'm just trying to make sure I finish my slides in time. So I'm here.
You're totally fine.
So plan B if he's not available.
Sorry. Dr. Esch is our plan B if Dr.
Yeah.
is not.
Well, talk about what vaccines was he going to talk about, Dr. Esch?
He was going to talk about MMR. Yeah.
Okay, I can also as well. We can all, help with that for sure.
Welcome back to the Flint Community Webinar, your community resource. We're so happy to be back here with you today. Right ahead of Thanksgiving, I want to reach and give everyone a happy holidays ahead of the holiday if we don't get to see you. We've got a lot of wonderful things to talk about today. We're going to talk about vaccines, how we protect our families and strengthen our communities. I'm really excited today because we have wonderful expertise in the room. We've got our wonderful Doc G and Nurse T, but also we have our local pediatrician, our wonderful local pediatrician, Dr. Esch. We might have a cameo appearance from our wonderful chair of the Department of Pediatric, Dr. Keith English. And we've got Joanne Herman and Dr. Lyroff here. So we've got wonderful people here to talk about the vaccines that we need to make sure we're protecting our communities and our loved ones. We're going to go ahead and get right into it. All right. I believe we've got, okay, perfect. Dr. Esch, talk to us a little bit about the vaccines we should be thinking about. And even if we are more specific, could you tell us a little bit about measles and what we're seeing in the community and what we should be thinking about in terms of how to protect the loved ones, our loved ones?
Yeah, absolutely. I think our friends from the health department, Joanne and Leah, are going to talk more specifics about numbers. So I'm interested to hear more. But just to get us started, right now we, in the peds world, we're seeing some flu, we're seeing RSV. So already thinking about some of the immunizations that you can protect kiddos with just this fall. Measles, mumps, rubella, and varicella, which are traditionally known as MMR, and then V is the varicella. That's something that's on our periodicity schedule, meaning kiddos should be up to date. Generally speaking, they should get their first around 1 year of age and their second one around 4 years of age. I know Dr. English, who just hopped on, is going to go over that a little bit too. But I'm going to hand it over to Joanne and Leah to tell us the specific numbers in our community with MMR, and then we'll hand it off to Dr. English to talk more specifically about that immunization.
Thank you so much.
Thanks, that sounds good. So let's start with our report card. We have a report card that's published out of Michigan Department of Health and Human Services, MDHHS, and that comes out quarterly for us. And this gives us an idea, just a snapshot, but an idea of how are we doing in Genesee County compared to the state of Michigan and then compared to the United States. So if you go in the first grouping, the 19 through 35 months, our toddlers, and if we look at our MMR rate, we're at 79.4. And look at the United States, we're at 93.1. So that the first, right off the gate, I could say we've got some work to do in terms of MMR coverage compared to the rest of the country. And we can also look at DTaP because we'll be talking about, as we talk about pertussis, or if that should come up, we're at 70%. In our country, we're at 87%. So you can see how we fare for our toddlers. And that trend line, and we'll talk more about trend lines, we really are dipping in, not just in Genesee County, but in the state of Michigan, compared to the country. And the country is dipping as well. So let's go down to the teens. And we look at our 13 through 17-year-olds. And we can look at how we're doing overall. And I'd say in Michigan, overall teens are flat in terms of their coverage, but we have some noticeable changes in Genesee County. For example, let's just look at our HPV rate at 37.3 compared to 62.9 for across the US. And this is on the early end of really looking at COVID and flu, where we stand across our community. But we do know that our uptake rate right now is down. And not to depress you more, but our waiver rate is being published right now. We just finished with the reporting period for preschools, and our childhood reporting period is in the midst. It just, the reporting period just closed out November 1st. But the people that do waivers, my teammates at the county, would tell you that it's definitely increased significantly. And we're hearing the same thing across the state and across the country that are waiver rates. So let's look at it a little bit in terms of trends. So this is just looking at a snapshot, but let's look at our trends and where we stand across our county. So what I'm going to show you next is a report that will look at let me just wait for that to come up before I start talking. So here we are, March 2020, statewide. Purple, that looks good. That's 80.8% to 83. Now look at it compared to March of 2025, and you see a lot less of that intense purple across the state. Look at that, 5 years, and our trend line has significantly changed. Leah, anything you want to add to that?
Oh, so it varies differently by age. So for our little ones, this is going to be largely, I don't know if Dr. G, you want to talk about this too, or like our missed well baby visits during COVID shutdowns would have contributed to this number specifically. And then as we get older, so we go into the 4 to 6, it's not as dramatic. And then when we go back up again to our older kids, 13 through 17, it's a little bit less dramatic of a shift in terms of rates by year. But making sure that we get to those appointments so we're getting good health information is so important. And this is a really good picture of that.
This is outstanding. I wonder if we could, there's some interesting comments in the chat that I think are important, both from Dr. Lyroff and Dr. Esch. Dr. Esch was saying that the waiver rates are waivers submitted to not be up to date on kindergarten required immunization. So important context that we should be aware of. And then Dr. Lyroff was mentioning this is especially concerning because the outbreak earlier this year in Texas, the vaccination rate was as high as 82%. So we're not
and ours was lower. I mean,
yes,
our rate was lower. So when Texas had their outbreak, I think Dr. McCullough called that out. He said, how are we doing in Genesee County? And I said, our rate is lower than Texas. So what this is telling us that our vulnerability of vaccines across the board.
Yeah, and I am in no way trying to steal your thunder, but just one quick thing. The big issue too, it is good that kids are catching up, but measles causes really severe disease in babies, and it's oftentimes like these kids are the most vulnerable. So even though they do catch up, it's still a major concern, as I know you Joanne and you Leah and everybody on this call are well aware.
Yeah. So we've got a question from some participants around if we understand why the rates are lower.
Yes. It's a combination of access to providers, good health information, and then also the vaccine hesitancy. So we're seeing a lot of misinformation, disinformation, and just confusion around the schedule and vaccines broadly. So making sure that we're getting health information from a provider is going to be like the biggest ask as like a community member, right? Because we want to make sure that we're getting good information because there is so much information available to us. Really narrowing down what is like right for me as a patient is so important to get from your healthcare provider.
That is such an important point. And as we talk about that, I want to bring Dr. English into the discussion. As we think about Dr. English's expertise, our pediatric department is a statewide department. So Dr. English sits over our pediatrics department that has the benefit of understanding trends across our entire state. And so we live in 8 different communities across the state. And Dr. English, I'm curious if you've seen similar trends across the state and if there are things that maybe you think we should learn from places that may have done this well, or from things that you're seeing in your expertise or your environment.
Well, can you hear me?
We can.
I have some slides I could share in a minute, but I don't really need them for right now. Yeah, I would agree with everything that's been said so far. I think we're very fortunate that we haven't had more cases in the state of Michigan. I think we've only had 29 cases of measles looking at the website yesterday. 15 of those were associated with 3 outbreaks. So we're fortunate that there are only 3 outbreaks in the state. We had a single case in Ingham County, 4 cases in Kent County, but not related to each other. I don't think Genesee County's had a case, as far as I know. So we've been lucky that it hasn't been worse. But if you want to look at this week, as we've had really depressing news that there have been 5,100 plus cases in Canada, most in Ontario and Alberta, and Canada now has lost its measles elimination status, which it got around the time that we did, 1989, 98, 99, 2000, that time. It's sad news. Mexico may lose its status next, so we may be surrounded by 2 large countries that have lost their measles elimination status. And there have been 1,723 cases in the United States and 3 deaths. And there had not been a death in the United States from measles in a decade. As people said earlier, very importantly, measles is particularly dangerous to young children. They're more likely to be hospitalized. They're more likely to develop life-threatening complications like encephalitis. They're more likely to get secondary bacterial pneumonia. And even if they do well, years later, they're more likely to get terrible complications of measles like subacute sclerosing panencephalitis, which is actually more common than we thought it used to be. And there was just a case of a child who died in Los Angeles County who had had measles as an infant. Having measles in the first year of life greatly increases your risk of that complication years later. So there are all these reasons, and I have to give my soapbox comment, which is the WHO's estimate is that measles vaccine saved about 94 million lives around the world between 1974 and 2024. Think about that for a minute. About 150 million lives were saved by vaccines, not counting smallpox, not other diseases that you could have had you not had the vaccine. So about almost 2/3, well, more than 2/3, almost 3/4 of those were deaths prevented from measles. And yet, how can we be in a situation where we are in danger of having more children show up with measles again? It's really a national disgrace, I would say, that we're in this situation.
Dr. English, you said a couple of important things that I want to make sure we follow up on. So a few of our participants are asking, what does it mean for a country to lose its measles elimination status? And are we surprised by that? And how did we get there? And I wondered if all the expertise would explain that. Go ahead.
Yeah, I got a slide somewhere, but I don't think I really need a slide. If you look at the data, back before we had the vaccine, there were something like 5 or 6 or 700,000 cases a year reported in the United States. It's believed that the actual number of cases was more like 3 or 4 million. This is before we had a vaccine over 50 years ago. And at that time, measles, by the way, measles is probably the most contagious infectious disease. It's estimated that the R naught that the British like to talk about is 12 to 18. So one infected person will infect that many more people if they're not immune. So you can think about how quickly that spreads through a community when those 12 people infect 12 to 18 more. You can do the math. So it's a really contagious disease. And what happened in the United States was we were making good progress at reducing measles, but we still had outbreaks. And then in the late 90s, 98, 99, actually, two good friends of mine who trained with me at Baylor were involved with an investigation of an outbreak in Texas that led to the recommendation to give a second dose of the MMR vaccine. Prior to that time, we gave one dose. And it was pretty good, but there were about 5% of people that still could develop measles. By giving a second dose, it's more like 2% of people that can still get the disease. So since we've given two MMRs, we've eliminated, quote, endemic transmission in the United States. That is, to get measles in the United States, even this year, many of the cases came from Canada, right? We didn't have endemic spread in this country. Once you have endemic spread, there's a specific definition for how many cases there are and how long the transmission continues. But the bottom line is we're in a situation where we haven't had endemic spread for 25 years, but we're in danger of having it again now as our immunization rates have dropped. I should mention that Canada had only like 100 cases of measles total over 3 years at one point. Then their immunization rates dropped. They had over 100 last year and almost 5,200 this year. So measles is the canary in the coal mine. It's the most contagious disease. You quit immunizing kids, you will see more measles first.
I appreciate you explaining that. Dr. Lyroff, as you kind of give your expertise about this, I wonder if you would also explain what endemic spread is so that everyone knows. Because I understood, but want to make sure that all of our audience is following with us.
No. Absolutely. I think Leah actually answered it really well in the chat.
In the chat, I saw that.
Yeah, basically just means community spread from person to person. I want to add to that. I was recently at a presentation on the measles outbreak in Ontario, and it was really interesting because they actually have an 88% vaccination there, but lower vaccination rates, particularly in Alberta. And they found that in the majority of cases, it was actually in kids who were in their appropriate vaccination schedule in that 2 weeks after getting the vaccination before immunity kicks in. And so it's just really important to remember you need about 95% vaccination really for herd immunity to measles. So anything less than that makes us all vulnerable, even kids, even families that are, not anti-vax and are on appropriate schedules. So just a really interesting cautionary tale of what was going on in Ontario. And I also just wanted to emphasize, obviously this is something I'm passionate about, so I apologize if this is too much, but the risk with measles is really the risk and complications. A lot of people say, what's the big deal? It's just a virus. I've gotten a million viruses. But I think they say about one, and you can correct me, Dr. English, if these numbers and Dr. Ash are correct, but I think it's about 1 in 4 people who get measles gets hospitalized. 1 in 20 get pneumonia. 1 in 1,000 get cerebritis or encephalitis, and 1 in 1,000 die. And those rates are really pretty high for pediatric diseases, especially. So just want to.
You bring up a really important concept of herd immunity, right? So, that's one of the big issues of why we're so concerned, not just that we're concerned about if, we were to have a measles outbreak, but also we have to consider the people that may not be able to get immunized, the people that may be at higher risk, even if they've been previously immunized. So thinking of our people whose immune systems aren't as good, if you will, as others, or pregnant women. And so teeny tiny babies. So people who can't get immunized are at risk. And another comment I'll make, and this is what I tell all the parents I see, I got my 2-year-old immunized with her second MMR for that terrifying complication. Sclerosing encephalitis can happen. You can get measles. And the risk under 2, you can get measles. And if you're under 2, you're high risk for, you might recover, but then 10 years later, you might die from it. And so for a number of reasons, I got her immunized for her second one. But that was one of the things that I was like, I'm not messing around with us having measles in the state.
Yeah. One of the things I always appreciate about Dr. Ash adding to the conversation is she will never tell you something she is not doing for her own children. And the same is true for me. So like as soon as we can, we are all getting all of our own loved ones vaccinated. There are a couple of questions if I wondered if you all would try to answer as we talk about it. Darlene brings up the excellent point that we need to think about our people who might be exposed. So people who might be carriers or people who might be exposed, immunocompromised, pregnant people who might be at risk, although they may have received vaccinations previously. Can you talk to us a little bit about those populations that might be at more risk?
Sure, probably several of us could do it. I'll make a quick comment. One of the 29 cases in the state of Michigan was a child who had 2 doses of MMR but was immunocompromised. One of the reasons, when people tell me, gee, I just want to have the choice for what I'm doing for my child, I'm thinking, how about the children exposed to your child? They don't have a choice. I mean, if you don't want to get it, if you don't want to get immunized against tetanus, you're putting yourself at risk, but you cannot transmit that to another person. Measles is incredibly contagious. So if you don't get immunized or your child's not immunized and your child gets measles and gets over it, but gives it to an immunocompromised child who might die, there's a problem there. So young infants, immunocompromised folks, the elderly, pregnant women, all of these people are at increased risk of more problems with measles. And I love the comment you made earlier, Dr. Leroff, about the complications and people not understanding measles being, quote, just a virus. I don't know if you've ever seen it, but there's a famous episode of the Brady Bunch where the kids all one of the kids gets measles and they all go home and they play and somebody painted some spots on their face and they're so happy not to be at school. Measles is not a disease that made you feel happy that you're at home. You were sick. Even the kids that didn't get complications were ill for days. It's a bad disease. And unfortunately, we're victims of our own success. We eliminated endemic transmission in the United States so people don't remember measles. And then you have people like Robert F. Kennedy Jr. We should all get measles. It's no big deal. That's just wrong. So we do have to figure out a way to do a better job of educating people. And what does not work is yelling louder than the anti-vax people. That just plays into what they do. We have to figure out a way to educate better. And I think we have to have more peer education.
I love this. I want to let people follow up on this, but I certainly want to follow up on what do we do in response? So after Dr. Ash and anyone else gives their comments, I want to get back to that.
I was just going to make a quick comment on pregnant women. Pregnant women cannot get immunized for MMR while they're pregnant. And so if they are unimmunized, they're at risk on top of the risk of being pregnant and having a lower immune status. And then their fetus is at risk. And so fetuses, unborn children are at high risk for complications, various complications. They can have heart problems and hearing problems if mom contracts measles during pregnancy. So, thinking of this ripple effect. And I liked Leah's response of improving vaccine confidence. I think some of this is telling people that we immunize our own children. Some of this is talking about how safe vaccines are. So vaccines are so safe. They've been tested again and again. I think improving vaccine confidence and sharing the information that we have and why, for example, we are so confident to immunize our own children.
Yeah. How many of you... No, go ahead, Dr. Leroff. I'll follow up with my question.
No, I'm sorry.
This is great. Thank you.
I just wanted to say also, these days, a lot of times MMR is also given with the varicella vaccine. And that's also one that can't be given in pregnancy and can cause, if someone gets varicella in pregnancy, it can cause severe congenital problems. And so another risk is, not having had that virus and then not being able to get the vaccine when you're pregnant.
I think those are such wonderful points. The question I was going to ask the providers on the screen and anyone else who encounters this regularly is, how often do you see side effects of vaccines relative to how often you see side effects of not having been vaccinated?
That's a great question.
Anyone who
Well, I have read lots of numbers that feel very unrealistic, right? That like putting yourself in a percentage, if like 10% of people get this X thing, it's really hard to imagine that, right? But you are 333 times more likely to be struck by lightning than you are to have a serious adverse event from a vaccine. That's the risk that you're putting yourself in not getting vaccinated is just so teeny tiny that you're more likely to be struck by lightning.
I love that
And
from media because I'm going to let you follow up, Dr. Esch. I love that because I think as providers, we have to recognize that there is a risk, right? A risk exists. There are side effects. These things exist. You're not, the things you are reading that are appropriate. The risks exist. They are just so much lower than the risks that happen due to the disease that we're trying to vaccinate against. And that's the big thing that we all sort of tend to encounter. So I want Dr. Esch and then Dr. Lyroff to follow up because I saw Dr. Lyroff get all excited.
I think that you make a really good point in mentioning serious adverse events. The way that we look at adverse events or side effects or whatever you want to say for immunizations, we even track like little stuff, not serious stuff. So I have parents coming in saying that their kiddo's leg hurt, or sometimes after an MMR immunization, you can get like a little lump on the leg in the area that the immunization was. We would consider that an adverse reaction or a side effect, if you will, but it's not severe and not serious. But if you think about, especially thinking about like flu shots and the severity of illness, seeing sick kids in the hospital, seeing as many pediatric deaths as we saw last year from influenza, thinking about my kid has a sore leg for a day versus my kid ends up in the hospital, right? So we also have to factor into, how the severity of the illness versus the severity of the adverse effects as well.
Yes.
I was just going to say, I think there's a couple of things at play here. One is that risk is really hard for any of us, even medical people, to think about as immediate risk. And I completely understand that. And I also, when I have these conversations, like to admit that we've gotten it wrong in the public health community in the past. If you read about the history of vaccinations, the history of medical experimentation, there are a lot of problems with it. And there were bad things done to lots of people. So I do think it's worth acknowledging that I understand why people have concerns. It's not crazy. You're not ignorant. You're not stupid. But I will say, all of these vaccines that are available now, they really have such robust data. They really are so safe. And I try to kind of go from that perspective. And if someone doesn't want a vaccine during one appointment, I say, that's fine. Read about it. Let me give you some resources. Let's keep this conversation going and we can talk about it next time. Really, I want everybody to feel comfortable with it. And I also think it's important to not discount the very real experiences that people have. I also think that something that's challenging is you get these viruses right you get these vaccines, especially like COVID and influenza that we're going to talk about during viral season. And so it's not uncommon to get a vaccine and then still get a respiratory virus. The average adult, I think, who doesn't have kids or work in healthcare gets 2 to 3 respiratory viruses a year. So, we're all sick all winter, even if you get your vaccines. And it's really about understanding, what you're preventing and what the risks are associated with the specific infections that we're trying to prevent, admitting that we don't have vaccines for everything, including a lot of common cold virus.
One of the questions that was asked is, what are the resources and barriers to access in Genesee County? And I want I wondered if our health department people might speak to that a little bit, but I know we also have some of our GHP friends. I saw Jamaica and I saw a couple other colleagues. So if we want to bring them to the discussion, it might help us round out this idea of, okay, what are our barriers in Genesee County and what are our potential resources?
We can show you I'm going to show you
Go for it, Joanne.
Yeah, a census tract map that we have that I think will be interesting for you to see right here. So looking at, let's get it back up there. So looking at, this is Genesee County. And so we did a deep dive looking at where do we have issues? Where is our uptake poor? And how can we focus our attention? It looks at just different age groups of kids, 19 to 35 months. You can look at the teenage years. And essentially what we found is we have issues of uptake throughout our county. There isn't like, this isn't limited to the city. This isn't one suburb area. This isn't one rural area. Essentially, all areas of our county have issues with uptake. Then we did a map looking at where we in the health department, we take that very seriously. How can we improve our access? And where do we have, you show that, Leah?
Yeah, I just wanted to point out too, that there's not necessarily a correlation. There's not like a good relationship, right, between being close to a healthcare provider and then being vaccinated, right? So we've got a big section down here that has a pretty low vaccination rate, and that's the strip of Saginaw Street and Grand Blanc with all of those healthcare providers that are on it. So it's not necessarily proximity to like how close you are to a doctor. It's really a lot of factors layered on top of each other too.
That's super helpful to understand.
Yeah, because we really want to look at where do we need to improve our access rate. So we just mapped out in Genesee County, like where do we have little pop-up clinics? We're consistently at the health department. We do Saturday clinics. But we really looked at where are our efforts for pop-up clinics, and we'll be adjusting this because I think this was good information for us to see where are we and how can we improve access, our hours of operation, just to make it more accessible to our community at large.
That is amazing. Okay. Dr. English just shared the most adorable picture because he too is of the I'm going to vaccinate my loved ones. So I don't know if we can bring it up really quickly. And then I want to hear from Jamaica. I can see it.
There
but
it is. So
go ahead.
So I don't know if you know Veronica McNally. She's a professor in the law school at MSU and is the leader of the iVaccinate.org program that started in the state. And she recently was our Heaven Rich speaker, and I shared this picture of her with my 3 grandsons wearing their iVaccinate t-shirts. They're all vaccinated. So one thing that really angers me as a pediatrician when I hear somebody say, well, pediatricians, they're out immunizing kids to make money. These are people that are not very good at math. Apparently, because pediatricians often lose money giving immunizations. But the idea that Dr. Esch or I or our colleagues are recommending immunizations because we're, quote, in bed with the pharmaceutical companies is just personally infuriating to me. Why did I make sure my kids were vaccinated? Why do I make sure my grandkids are vaccinated? I mean, that it's just, it's shameful, really.
Yeah, that's such a wonderful point. Thank you so much for talking about that because I think it is really relevant. We make very, very little money. We don't make money off the actual vaccines. Most of us are in healthcare because we want to improve the health of society. And I know all of us in some way are working to contribute to the health of Genesee County. As we think a little bit about that, Jamaica, and I know we've got Nurse T here who always has our pulse on what's going on in terms of vaccines. So I'd love to hear from her too. And I see Yvonne Lewis back there. So any of our colleagues who want to talk a little bit about the efforts in Genesee County to bridge this gap and make sure resources are available to the community, I want to make sure we hear from you. Jamaica, do you go ahead, Nurse T, and then Jamaica.
No, I was just saying sometimes it's not the fear of the vaccination or that the patients don't want the vaccination. They don't have a relationship and they don't trust the healthcare provider that's administering the vaccination. A lot of times when we were out there doing vaccinations and my mom up there, Miss Herman, can testify that they took the vaccination even if they had fears, because they trusted us and they understood that we cared about them, and they didn't feel like they were just a patient that was receiving a vaccination. Because sometimes really patients don't know. They'll ask their physicians, the nurses, anybody that's taking care of them, as you know, well, what is best for me? What do you think? And when they ask that, they're more able to be compliant because it's coming from your personal and your professional perspective, but you have made them feel comfortable and they trust that their healthcare provider has their best interest at heart. So I just think if we just continue to mobilize services, give opportunities for vaccinations, and let the community know that we care about them as a person first. And
That's
that
right.
the reason we're doing this is because we want them to have better healthcare outcomes.
Amen.
Yeah, we know we know that 90% of healthcare professionals, our nurses, our physicians, are that trusted source. 90% believe that we are a trusted source, and that's why providing that strong recommendation, that grandparent story, whatever that is so essential for us to be able to succeed.
Thank you so much. Okay, I want to hear from GHP and understand if there are things we need to be making sure that people are aware that GHP is doing to help bridge this gap. And then I know, Leah, you have some wonderful slides that we should be thinking about on germ theory and how we should wash our hands and how we can otherwise prevent things like this from happening. So I want to just going in a circle here. I think it's Jamika from GHP and then Leah.
Yeah. Okay, go right ahead.
I am so excited that we are having this conversation. And just from the Genesee Health Plan perspective, the health plan hosts a vaccine event every year to welcome folks to come in and get their vaccines. We work very closely with the Genesee County Health Department and some other community partners, Walgreens, so that folks can drive through, get their vaccines, or come into the office to find out what vaccines they need from the health department. And more importantly, the Genesee Health Plan is here to help folks who don't have healthcare insurance. We are currently in an open enrollment period for healthcare insurance. If you need Genesee Health Plan, Medicaid, Medicare, if you need to shop the marketplace, we want folks to be able to explore what their healthcare coverage options are. We don't charge fees for those services. Our office is open Monday through Friday from 9 to 5 for an appointment to explore your healthcare coverage options. So that folks know that they can have a medical home, a primary care physician where they can go and get vaccines. So Genesee Health Plan has been here for 25 years, serving this community for the purpose of healthcare coverage for all residents of Genesee County.
Thank you, Jamika. We appreciate GHP so much and everything that they bring to this community, including this discussion, which is so important. I know Dr. English had some slides, and I know, Leah, you were going to talk to us. I also appreciate the comments you put in the chat, and I wondered if you'd give more context to that conversation around the affordability of vaccines and vaccines for children.
Yeah, so I believe all of our providers all of our pediatricians in Genesee County are a part of the VFC program, which provides free vaccines to anyone under the age of 18. And then it's dependent on health plans too. So what your health insurance company provides in terms of coverage for vaccines. And then are you on Medicaid Part B? And then where are you going for those vaccines? So a lot of our adults are going to go to a pharmacy because of the Medicaid covers vaccines at a pharmacy, whereas it's not going to cover as much of it at a primary care office, or maybe your primary care doctor doesn't carry vaccines in their office. So having that relationship with your pharmacy as well, and just getting those there if that's where it's going to be covered. And then we also have grant dollars at the health department to bridge some of that gap too, right? So we publish our outreach clinic our outreach clinics, where they're going to be at and what time of day they are, on our website every month. And we can work with you on payment structure, pay scales, and we can cover a lot more of that cost for you if you're uninsured or underinsured, because we have some excess grant dollars. So we have a little bit more wiggle room and can be helpful in an outreach setting.
Just even with the COVID, where there was some question about what would be covered and what would not be covered, the Michigan Department of Health and Human Services, Dr. Bagasiarian, defined that all residents who are unvaccinated or not current with their vaccines, like in the seasons, are considered high risk. So any questions other states were having about how do you define high risk, essentially in Michigan, we were very lucky because anyone that wasn't up to date with that vaccine was high risk and therefore eligible to receive that COVID vaccine. So we are lucky in Michigan with some of that affordability that helped our pharmacies, our health plans, and all of us as citizens.
Yeah. We're lucky in Michigan because we have all of you. Like that, this expertise is really just phenomenal. From Nurse T being out in the community all the time, from GHP being a resource to people. It's really exciting to have all of you here. I'm like super excited myself just thinking about it. I wanted Leah, you to get an opportunity to talk a little bit about germ theory and why washing your hands and all of that is important as an adjunct to kind of some of the things we've discussed. And then if Dr. English had any slides that he didn't hit, I wanted to give him an opportunity to make sure we learned everything we could from him as well.
Oh my goodness, yes. So one of the conversations happening in a lot of community spaces is, well, the measles rate was already going down before we had the vaccine. So what really is the importance level, right? So I wanted to share just some information I've seen a couple of my wonderful, lovely friends share online, and I really wanted to dive in deeper if we have just a minute.
Yes.
It's not just necessarily that we learned how healthcare works, right? There was a period of time where we weren't even washing our hands before we were delivering babies, right? So we've learned a lot, and we saw measles rates start to go down, but it has like this fun 5-year spike, right? So we saw this really cool improvement, but our measles vaccine was introduced right here, right? This is the first dose. We talked about how there was a second dose added. But I want to zoom in because we learned a lot and science has continued to improve, but I wanted to zoom in here. Okay, so we were still seeing, we know and have had conversations about how high the risk is for getting measles, right? So when we saw that first vaccine licensed, we see this huge drop again. And then when that second dose was put in place around like 91, that's when we got our elimination status, was after that second dose was introduced, right? So conversations that are being had in the community around just germ theory and, well, you can wash your hands. And it's really because we learned a lot about science and healthcare, and we have better immune systems now, right? But it's not just that. We learned a lot and a lot changed and improved over time. But this last piece of the puzzle, are one of our most effective vaccines, right? We got to our elimination status, and it really pushed us down to that last elimination piece, right? So I just wanted to share that and give some perspective, because we have learned so much and we're still getting better. And
Uh-oh, we lost you. I think Joanne and Leah are trying to tag team their audio. So sorry. We lost the last sentence there.
Oh, that's okay. We're always improving. So we're always learning, we're always growing, we're always learning new things. So when things change, it's because we've learned something new. And it's for a good reason.
That makes so much sense. Dr. English, I want to let you close this topic out, but I want to underscore a point that was made in the chat, which was to champion the comments made by Dr. Learoff around why people in the community experience vaccine hesitancy and how all of us take responsibility for the idea that we historically in medicine and in public health have not done our due diligence, have not recognized communities, have experimented on marginalized communities and communities of color. And so it is really important for us to do this education as we try to correct some of the things we have gotten wrong in the past. It's important for us to make sure that everyone has the education that they're supposed to have, that everyone has access to what they need to. And our goal as a webinar has been to be that trusted, accessible voice and bring to you people like Dr. English, who's doing some of this work. So Dr. English, if you would like to close us out on this topic, and then close us out. And I know Lyroff had a couple last things about vaccines in older adults. So if you two want to tag team, that would be wonderful.
Sure. Let me make a couple of comments. I absolutely agree that we absolutely should understand why it is that many people appropriately have distrusted the medical system because they've been treated poorly by it. And that's why we need better outreach, and that's why we need better partners and allies in the community. What we don't need are experts preaching about it on television. We need connections with individual patients and families. And the experts can help with that, but they're not the people. I mean, Tony Fauci got all kinds of inappropriate criticism during the pandemic, but he was never going to be the most effective person to convince an uncertain person to take a vaccine. He was a talking head on television. You wanted to know, what do my friends think? What does my church think? What does my community organization think? How about the schools and how they, work with the kids? So that's very important. So part of this is our own fault in medicine for doing a lousy job for many years. We're doing better, but we still have a lot of improvement to do. But it is making the connections in the community. That's what makes a difference. I love programs that have used community organizations around the country. We had a number of these in Memphis. Churches were a key place where you could get your flu vaccine every year. Those sort of things really work. Connections that you already have makes a difference. And then, of course, your relationship, if you have a pediatrician working with your regular doctor, makes a big difference. I did want to, unfortunately, make a cautionary note, which is, as much as I love vaccines for children, I worry about the future of the program, given the fact that the Advisory Committee for Immunization Practices, including several friends of mine, were removed from the committee and replaced with a number of people who don't have any expertise and who are clearly against vaccines. So I'm worried that if the ACIP next month says, well, you know what, we no longer recommend the birth dose of hepatitis B vaccine. Well, if insurance companies decide not to cover it based on that, that's a problem. Young children will get hepatitis B and some of them will die from cirrhosis or hepatocellular carcinoma. So as everybody knows, I think the American Academy of Pediatrics and now some states are developing their own sort of shadow guidelines. And so hopefully insurance companies will look at this and say, well, the real experts are these experts in the American Academy of Pediatrics, et cetera, and we're going to follow their guidelines. But we're about to have a tussle between guidelines based on expertise and guidelines that are based on trying to undermine vaccines, just to be perfectly clear. So I'm worried about that. Having said that, I do think also I have to mention that while we need to be honest and say every vaccine, just like every medication, including Tylenol, has potential side effects, although Tylenol does not cause autism, MMR does not cause autism. We have to also be able to push back to say, but that's not actually a side effect of this vaccine. Now, and I have a whole talk on Andrew Wakefield and a fraudulent study that he published in 1998 claiming that MMR was associated with autism. It wasn't just a bad study. He made up some of the data. He lost his medical license. He was found guilty of fraud. And yet he was still at a conference in the United States last week with Del Bigtree, former chief of staff for Robert F. Kennedy Jr., in an anti-vaccine group. So we have to be able to say, you know what, there are some significant most side effects of vaccines are mild. A few are more serious, and thank God they're rare. But vaccines don't cause this. I mean, when people say, Robert F. Kennedy Jr. said this, MMR causes everything that measles causes. Wrong. MMR has never caused SSPE. MMR doesn't cause encephalitis in normal hosts. There are these very rare cases in immunocompromised patients. As someone said earlier, 1 in 1,000 kids with measles used to get encephalitis. 10 or 15% of them died. And a lot of the survivors had sequelae. So we have to be able to push back on misinformation, disinformation, at the same time saying, look, we understand your concerns. These really are side effects. Thank goodness they're rare, but the disease is so much worse. That's why my kids are immunized. So I am worried I'm worried in the situation that we're in right now, and we do need to do a better job of explaining things to everybody. Unfortunately, we have to.
Appreciate you. Dr. Lyroff, any comments?
She may be frozen.
I think she is. I know we had some trouble with her audio. Okay.
She's screen sharing. It's good.
Okay, perfect.
Okay, no, I'm on mute. Yeah, no, I agree with everything that you said. I would, my screen got messed up. One moment.
We can see you now.
I would also just add, oh, good. I would also just add that it is a particularly concerning time, of course. Even I was making some slides today, and a lot of the pages on like influenza and RSV that I visited a million times. I think an important time, and maybe appropriately in some ways, to really focus on community investment and building our relationships so that, we become more trusting providers. Somebody who made a comment in the chat about, needing more, I think it was Nurse T, about, needing to create more trusting relationships. That's really so true. And I think we have a lot of work to do in the community in that as well. I will also, and I will go through, what screen does it say today's goals?
It does say today's goals. Caitlin, I wonder if you try turning off your video because your audio is breaking up a fair amount.
Yeah.
Yeah. Okay. I know my connection is, let's see.
Okay, I think we can hear you.
Okay. All right. Yep. So my video's off. So what I would just wanted, I'm going to go through this really, really quickly for you guys. But I did want to just touch on some other vaccines for older adults. In addition to very young children, adults over the age of 65 are at risk for severe manifestations of most things, but also respiratory viruses. And there's a lot of questions about these vaccines, and there's also been some new movement in the vaccine front as far as the RSV vaccine. So we were going to talk about this today. So adults over 65, they have the highest risk of hospitalization and death from the flu, influenza, and pneumonia. Pneumonia is always in the top leading causes of death every year for adults, not an insignificant thing. Immune systems naturally weaken with age, at risk for these infections, and they are often also more likely to have the chronic underlying conditions that lead to these poor outcomes. But vaccines can significantly lower the flu. We all know it's a contagious respiratory virus. The flu seasons vary each year because the virus that causes influenza, the way its genetic material it can kind of rearrange with other influenza viruses and create novel strains. And this is why every year there's a new influenza vaccine. And also why every year, we guess what to make that vaccine as by looking at viruses in the southern hemisphere, because they're in winter when we're in summer. And so every year, at best, it's just a guess. But we do the best we can. Complications from pneumonia itself and influenza include heart attack, stroke, and also worsening of chronic conditions. So everyone greater than 6 months and older should actually get the flu vaccine every year, unless there's a specific contraindication, such as anaphylaxis to prior vaccine, history of Guillain-Barré. As I mentioned, they are updated each season to match the circulating strains as closely as possible. But even when we get it wrong, like maybe some years the influenza vaccine may own 20% effective. Some years it's 80% effective. But even if it's 20% effective, we have really good data that if you get the vaccine, you get less severe influenza. There's a lower rate of hospitalization and there's a lower rate of complications from the virus. So there's still good reasons to get the influenza vaccine, even if it's not a particularly great match that year. And then importantly, and this is for the flu vaccine, but also for all vaccines, it takes about 2 weeks after vaccination for protection to build, which is why we recommend getting the vaccine early fall, September to October, so you can build up immunity before flu activity peaks. And it's okay to get vaccinated later if you haven't yet. Better late than not at all. And these days, they're giving flu and COVID vaccines often at the same visit, but you can also dose vaccine recommended for adults 65 and older. And these higher dose vaccines generally produce a better immune response. Some notes on safety. The flu vaccines have been used for decades. They have a very strong safety record. They do not give you the flu. It's not a live vaccine, but like I said, because you give the vaccine during a time when there's a lot of respiratory stuff going on, you can still get sick with other vaccines, even if it's not the flu. And even if it is the flu, you'll be better protected. And also, there is that 2 week period, which you can still get a severe manifestation of a virus while you're building up immunity to it. So it takes about 2 weeks for all of that to kick in. Um, oops. Okay. And I can talk about the rest of this later, but just big thing, please get vaccines. One other vaccines available for older adults, of course, are the COVID-19 vaccine and then the pneumococcal vaccine. Most adults can now get a single dose of the vaccine, the PCV20. And then the RSV vaccine is a newer vaccine. I just want to mention this really quickly. It's a one-time shot recommended for adults greater than 75 or those between 50 and 74. And it can also be given to pregnant women to prevent RSV in babies, which is a big cause of asthma, actually, in young kids before the age of 5. So with that, I will end here, but I'm always happy to talk more if people have questions and let Dr. Edward Johnsons take it.
I appreciate all of this expertise so much. I want to reference that we are having this discussion because one of the members of the community asked us to. And this is exactly, I think, how this is supposed to work. We're supposed to grab the data that people want to know from the community. Dr. English, you have 10 to 15 seconds because I got to bring on our wonderful Children's Museum. So please go ahead.
I just really appreciate that update on the vaccines for adults. I want to make one comment about the monoclonal antibody that's being used so successfully to prevent RSV disease in infants, nirsevimab. Ironically, one of the reasons it's been very successful is we do not call it a vaccine. When we give passive immunity, we don't use the V word, and I'm confident that's part of the reason the anti-vaccine group has not tried to oppose it. So let's not use that word. Let's call it nirsevimab. But it's reduced RSV hospitalizations by over 80%, a remarkable medication.
Wonderful. This is what happens when you let like 5 doctors come in a room together with their favorite people, the health department and community organizations. This has been wonderful. I super appreciate you. I want to bring Bart from the Children's Museum here because my kids and Dr. Esch's kids and everyone's kids I know love the Flint Children's Museum. And we're so thankful for you for being a curator of it and coming to talk to us a little bit about the programming you have here today.
Absolutely. Hi, everyone. My name is Bart, and I'm representing the Children's Museum in Flint. While we're not any sort of a medical center, our mission does relate closely to this panel and what we're discussing today. We want to create a healthy environment for all kids, and we also want to have kids be curious and thriving. I wanted to mention one thing that we're working on right now. Some of you may know, we're looking to relocate. We want to find a new forever home. Our current building is on the Kettering University land, and it's time for us to move because we're beginning to outgrow. Our main location that we're seriously considering is the Ferris wheel building in downtown Flint. If you're familiar with it, it's a very beautiful place. And we have a public survey that we want to share with everyone in the community. Anyone can answer it. We just want to hear all the feedback we can get before we make any major decisions, because the people are the ones who really keep us together.
That is so awesome.
Yeah, so I will attach a link to that form anyone can answer it. You can share it to whoever you would like, whether you've never been, if you're just a community member. We'd just be happy to hear anything, really.
That's fantastic. I appreciate so much you coming here and talking to the community and trying to get community input, because this is a resource, kind of like all the resources we've talked about today, that the community is going to use. And so understanding where you will best be so that as many people can come to the Children's Museum and enjoy health from a different perspective is really, really wonderful. How long is the survey going to be active?
As of now, we don't have a closing date,
Okay.
but I believe within the next few weeks it will be ending.
Okay. So everyone, as you're talking to your family over Thanksgiving, everyone brainstorm around where the best place for the Children's Museum will be and make sure you get it in the survey. Bart, we appreciate you so much, and everyone at the Children's Center. Thank you for talking to us about that.
Thank you for having us.
Of course. I want to give one last shout out to the Flint Cancer Consortium. We recently had a town hall last week. We are re-upping on this town hall. FC3 did such a wonderful job, and all of the people associated with FC3 have done such a wonderful job working to get the word out about our goals to understand potential cancer patterns in Flint and find out more about this cancer feasibility study. So we had a wonderful meeting this week, and next week, Tuesday, we will have another meeting. It is November 18th, 5:30 to 7:30. It'll be at the Flint Public Library. This week we were in our building at MSU. We want to be kind of directly in the community at the Flint Public Library. Ashley Kay will be coming back. She was at this week's meeting. Wonderful attendance, and it was just a wonderful opportunity to talk to people within the community, to share stories, to share resources, to share understanding, just like we did here today. So thank you all so much. I want to thank everyone again today who was here and contributed their expertise. Thank you if you are a community member who asked a great question and who helped us think about the things we need to be thinking about. If there are things you'd like to see on the webinar, just like this webinar was brought to you by Community Question, we want to hear your questions and we want to bring you the expertise you need. I hope you have a wonderful holiday, and we look forward to seeing you next month.